Still doing good.
So, welcome back to everyone who's online with us. We are doing psoriasiform processes today, and Shane was kind of dying to do this one.
So I'll see some parakeratosis, and below that some sponge, and maybe at a 45-degree angle there may be some exocytosis of red blood cells.
So there's some red blood cells and sponge and para. You put that together. What are you thinking?
PR.
So what if you had interface with red cell extravasation?
Then pleba or pityriasis like
Yeah. So interface with red cell makes you think pityriasis lichenoides. Sponge with red cell makes you think PR. Now it still could be contact, nummular, drug, could be any of those things, with especially if your patient's low on platelets. But it sure makes you think it's certainly compatible with Pityriasis Rosea. Is there any drug class that tends to give spongiotic eruptions?
Yes.
More than the others? Yes, good answer. And would you care to say what class?
I'm going to call on some help.
Okay. So anyone? What class? Calcium channel blockers. So calcium channel blockers overwhelmingly are the most likely. And you will see it. You will have, before it was described, I had old guy, father of a physician, who showed up with this just horrible refractory dermatitis. We tried everything. We tried phototherapy, put him on prednisone, put him into high output failure on the prednisone. He ended up in the ICU. And when he was in the ICU, they reviewed all his medications, messed around with them. He left the ICU with his rash fading, never to recur. They had taken him off as calcium channel blocker, and about a month later the article came out. Think meds for everything. You know, meds can cause anything, so you always look at any eruption. Now, at that time, dogma was drugs could cause anything except spongiotic dermatitis. Well, there are no excepts in medicine, and the biggest exception to that is the calcium channel blockers. That their version of drug tends to be spongiotic. Okay, so Paige, what do you think?
So, just offhand, I see some hypergranulosis, some orthokeratosis, and I'm wondering if it's maybe an alternating, like, blue and red pattern.
Not sure I'm seeing blue. I'm seeing red, and I'm seeing some serum in here.
Okay.
So there's definitely serum. What do you think about the epidermis?
It's kind of irregular acanthosis.
Irregular. So in psoriasis, it's a very regular acanthosis, and this is an irregular acanthosis.
It might be more like Lichen, simplex, chronicus.
And tell me about the direction of your papillodermal collagen.
Vertical.
Vertical, which certainly goes with LSC. Prurigo is a localized form of LSC, and this is overlying a scar. So scar with something that's chronically been picked or rubbed on top of it, giving you a prurigo, lichen simplex chronicus picture. Very good. You are absolutely correct. So kind of the two ends of the spectrum, from subacute to something more dramatic.
Okay, so got some hyperkeratosis. It looks very granular. So off the bat, I'm thinking maybe granular parakeratosis.
Granular parakeratosis. So you know about the third tablet from? Did you see History of the World?
No.
Okay, so this is an old Mel Brooks movie where he comes down from the mountain as Moses, and he says very loudly, "I bring you these 15," and then drops one in the cracks, and he says, "These 10 commandments," right? So there was that broken tablet from the movie, and on there, there are some of the Dermpath commandments. One of them is when what?
It's incredible, just odds-wise. I mean, it's all
Just odds-wise that they would have been all Dermpath.
granular.
Yes. That's right. So one of them is when you have parakeratosis, you lose your granular layer. And when you have orthohyperkeratosis, you have a thick granular layer. There are two sinners that break those rules. One is granular parakeratosis, where you have parakeratosis but granular, which is the opposite of what's supposed to happen. You're supposed to lose your granular anytime you get parakeratosis. Which is the sinner that gives you hyperkeratosis with no granular layer?
I'm not sure.
Anyone?
Ichthyosis.
Ichthyosis vulgaris. Okay. So anytime you have orthohyperkeratosis, you're supposed to have a big, thick granular. If you have a big, thick orthohyperkeratosis and you're completely lacking your granular, that's ichthyosis vulgaris. Anytime you have para, you're supposed to lose your granular. But if you have para with granular, that's granular parakeratosis. Okay. Two disease states that break the first two Dermpath commandments that just happen to be on that tablet that we have poor records of.
The missing tablet.
So what do you see in here?
I mean, the edge looks kind of poro-y, but it's kind of
The
still
edge
close
looks
together.
poro.
Maybe perhaps a baby photo of the poro before they have separated.
In fact, there are quite a number of cornoid lamellae in here, right? So this is porokeratosis. Remember, center of poro can look like anything, right? So it can look psoriasiform, it can look lichenoid, it can be hypertrophic. In this case, it's spongiotic with dramatic hyperkeratosis. But center of poro can look like anything. Just look for the cornoid lamellae at the edge.
So I see a little bit of sponge, and then you have some what looks to be exocytosis, perivascular infiltrate, also going down the hair follicles.
Yep.
Maybe about subderm, given the fact that it's on
Yeah.
maybe facial skin.
You might think of sebderm. Sebderm, you'll often have a scale crust that sits right here, lipping the edges of the follicle. Don't really see that in this case. I do see very dilated blood vessels, a few erythrocytes out. Not really dramatic. Clinically, this was PR. Looks more just like subacute sponge, right?
Yeah.
So subacute sponge with a broad differential contact nummular dyshydrotic, PR, little bit of red cell extravasation as a clue, but less than the last one. Helpful when it's there, obviously less helpful when it's not there. But history and clinical trump.
So this looks like a very acutely spongiotic process.
So an acute spongiotic,
And it's
And
acral
you-
skin, I think.
and it's acral skin. So what would be an acute macrovesicular spongiotic process on acral skin?
Could be dyshydrotic.
Yeah, dyshydrotic eczema would be classic. And how do you know this is acute?
Well, the stratum corneum is okay, and then the
So
vesicle
stratum corneum
surface-
is thick, but it's acral skin.
Right.
So it's normal for acral skin.
Mhm.
You don't have any papillodermal fibrosis. You don't have much acanthosis, maybe a tiny little bit. you have a big spongiotic vessel, and you have Langerhans cell microabscesses that look vase-shaped, opening to the surface. And the Langerhans cell microabscesses are typical of an acute spongiotic. They're the first thing that happens because they're still presenting antigen, right? So that's a very early feature in spongiotic dermatitis, is to get these little vase or flask-shaped Langerhans cell microabscesses. You can tell they're Langerhans cells because the nuclei are reniform rather than round. They have cytoplasm, whereas lymphs usually don't have cytoplasm. And they sit in a spongiotic dermatitis in a little vase-shaped collection, right? So that's Langerhans cell microabscess. If you stain them with CD1A, of course they're positive because they're Langerhans cells. We have seen kids mistakenly treated for Langerhans cell histiocytosis with alkylating agents for spongiotic dermatitis. So, that obviously would be a very bad thing. So,
especially if it's scabies.
Especially if it's scabies, correct. That definitely happens. So, Langerhans cell microabscesses are normal. They're supposed to be there in acute phases of spongiotic dermatitis. They do not mean Langerhans cell histiocytosis.
Okay. So, to broads and sheaves, are we on a mucosal surface?
We are, in fact, on a mucosal surface.
There's some spongiosis.
Tell me about the shape of the keratinocytes.
They're more square.
I'd say kind of flattened, maybe diamond-shaped.
I think I see like fungal elements in the top of the sternum.
So if you did actually just para,
okay.
simulating it, but certainly Candida can give you a subacute dermatitis. There are a fair number of plasma cells in the infiltrate.
So but isn't that a common? I mean, it's the mouth, so
correct.
Plasma cells, no matter
But
what
this
you're
one
putting in.
is not mouth. So plasma cells go with anything mucosal, but if this were a pink velvety lesion on the glands of an uncircumcised male, and it was rule out Bowen's, rule out Paget's,
You go back syphilis.
then syphilis or
Zoon's.
Zoon's. And this is actually pretty typical for Zoon's. So Zoon's is a chronic spongiotic dermatitis that can occur on the vulva, can occur on the glands. It can be male, female, circumcised, uncircumcised, but 99% are uncircumcised males. Tends to respond poorly to calcineurin inhibitors and corticosteroids, responds incredibly well to circumcision, and is characterized by a variably dense plasma cell infiltrate. Not a surprise given that it's on a mucosal surface. Spongiotic dermatitis with effacement of the Reedy pattern and flattened diamond-shaped, or some say lozenge-shaped keratinocytes outlined by, you can always see the little prickle layer, the little cell-cell junctions there between them. Very characteristic appearance for Zoon's, balanitis, or vulvitis, depending where it is.
Looks like parakeratosis. Maybe some neutrophils in there.
So parakeratosis, are you seeing newts or what are you seeing?
Granules.
Granules.
Granular parakeratosis.
Granular parakeratosis. Remember, you're not supposed to have a granular layer with parakeratosis. If you do, it's a pathologic condition, granular parakeratosis, which is usually axillary, not always axillary though.
Alright, so you get some irregular acanthosis. Pretty good infiltrate too.
Regular acanthosis, pretty good infiltrate.
Pretty faded, but looks like it's parakeratosis.
Para, and then what are these things that look like ants with segmented bodies?
Appears to have some newts.
Some neutrophils, and some of those neutrophils are in the corneum.
Mm-hmm.
You know anything that gives you newts in the horn?
So we've got a whole host of them. There'll be your P-tex differential.
Which includes?
Psoriasis, tinea, could be impetigo, Candida, sebderm, syphilis.
So that's pretty much your differential. So you're going to run down, and you're going to look. What kind of infiltrate do we have?
A gross one.
Okay. And the
Lots of plasma cells.
lots of plasma cells, sheets of plasma cells. So you may want to know, is this a Macarena site? And it's not particularly a Macarena site. It's just on the trunk. It was rule out Pityriasis Rosea.
And we surprisingly told them
Now you guys
that them and their partner should be tested. So probably
So-
syphilis.
Things that are clues to syphilis. Plasma cells present in about 2/3. The majority of cases of syphilis have a very peculiar type of acanthosis. Instead of being bulbous, it's long, slender, sexy, if you will, reedy ridges. So long, slender, sexy, reedy go with syphilis. Plasma cells, when present, the plasma cells are perivascular, but look at the vessel. Where's the lumen? There is none, right? So that's endothelial swelling when you have absence of lumen. It is spongiotic, but there's interface too. So mix of spongiotic and interface, you think of drug viral syphilis, drug viral syphilis, drug viral syphilis. What do you think of when you have a mix of spongiotic and interface?
Drug, viral, and syphilis.
Drug, viral, and syphilis. Drug, viral, and syphilis. Don't forget those three when you see that mix of interface and spongiotic. The other hints are you have an interstitial busy dermis. Lots of cells out in the interstitium. And the last clue is when you look at the lymphocytes, lymphocytes are usually black with no cytoplasm, but here you have definite amphiphilic pinkish gray background of cytoplasm. They're activated lymphocytes, atypical lymphocytes with ample cytoplasm. That's a clue to syphilis. This slide has pretty much every feature of syphilis you could name. About half of cases of syphilis have only 3 or 4 diagnostic features. They don't have all the features. Those tend to come from the trunk. They tend to come from older patients, and they tend to come with a history of drug eruption as the differential, or Pityriasis Rosea. That group that has few features, instead of having long, slender, sexy, reedy, overwhelmingly, it has effacement and loss of the reedy pattern. So it looks just the opposite. What are the most common features when you have very few diagnostic features? The ones that persist are endothelial swelling, busy interstitial dermis, too much cytoplasm to the lymphs. So newts in the horn you tend not to see. Long, slender, reedy you tend not to see. Plasma cells you tend not to see. Busy, you get effacement. Busy dermis. Too much cytoplasm to the lymphs. Endothelial swelling. You see that combination, you got to think of syphilis. Immunostains only pick up 70% of the current, because syphilis is a mix of spirochetes. About 30% don't stain with the immunostain. Silver stains worse, as bad as only 30% positive. So 70% false negative with silver stains, just because they're very insensitive. You guys have seen the control we use at Sign Out that is riddled. I mean, it's just wall-to-wall red on the immunostain, and you can hunt for an hour to find one spirochete on the silver stain. That's about your life with Steiner stains, or as we used to call it, the worthless starry stain. The silver stains are very insensitive. Immunostains only pick up 70%, so you have to suggest it based on H&E. And if there are relatively few features, it's going to be effaced rather than long, slender, sexy, reedy. You're not going to have newts in the horn. You're not going to have plasma cells. But you will have an interstitial busy dermis, too much cytoplasm to the limbs, and endothelial swelling. So if it's an older person and it's rule-out drug, and you see effacement of the reedy, you got no plasma cells, what things might suggest that you have syphilis? What features tend to be there?
Endothelial swelling.
Endothelial swelling.
Busy interstitial.
Busy dermis,
infiltrates.
almost suggests like interstitial granulomannulary.
And
Do your limbs look normal? What's wrong with them?
they are.
You're correct. Too much cytoplasm around those lymphocytes. Very good.
Very ample.
And if you have a mix of interface and spongiotic, what are you thinking?
Drug, viral, and syphilis.
And what if you have that interface and spongiotic and your dermis is kind of busy like GA?
Syphilis.
Syphilis, exactly. So, it leads you, and syphilis right now is at levels in the population like it was back in the 20s and 40s. There is a major recurrence of syphilis in the population. If you are not seeing syphilis in your practice, it is probably seeing you. Okay.
I see some focal areas of parakeratosis.
Focal areas of parakeratosis. What's going on in the epidermis?
Spongiosis.
Spongiosis, imagine that in this chapter.
And some extravasated red blood
And
cells.
extravasated red cells, so what are you thinking?
Thinking PR.
Pityriasis Rosea. What if you had interface plus red cell extravasation?
Pityriasis lichenoides.
And more likely pityriasis lichenoides. Very good. What if you saw a slide that had a mix of spongiotic and interface? What things are you thinking?
I think drug or viral or syphilis.
Drug, viral, or syphilis. And what if you were looking at that and there were endothelial swelling, too much cytoplasm to the limbs, and a busy dermis?
Syphilis.
Okay, very good. And, we say it again and again, and the problem is it's subtle. And if you're not thinking of it, you will not see it.
Okay, so you have some mounds of para there centrally
Mounds of para, and where are they?
around the follicular ostia.
And are they just para, or are there other,
There's some newts in there.
and a little bit of serum? So newts and serum, kind of lipping the edges of the hair follicle.
Probably good for sebderm.
Probably good for sebderm. Very good.
It looks pretty good for granular parakeratosis.
Looks pretty good for granular parakeratosis. And the features of granular parakeratosis are?
So confluent parakeratosis with retention of the granular layer.
Yeah. So, the features of granular parakeratosis are basically granular parakeratosis.
That's why it was Tommy's favorite.
Oh, it is
I think it's important to point out.
his favorite egg.
Okay, how about this one?
So I see focal areas of parakeratosis. There may be some newts on top of parakeratosis.
So there's a little debris here that's exogenous. I don't really see newts sitting right on top the way you would in psoriasis.
Okay.
But I do see a little bit of para. And where is the para in the epidermis? Or in the corneum? At the bottom, at the top, in the middle?
Kind of in the middle.
Kind of in the middle. So let's look around. And then there's para here. Where is it in the corneum?
On the bottom.
And how about here?
Kind of on the top, somewhere like a checkerboard.
So like a checkerboard parakeratosis, where it's at the top, it's at the bottom, it's in the middle. Anything that causes that?
PRP.
PRP, and another thing that can be very helpful for PRP is look where your follicles and your eccrine ducts come in. Sometimes there's a little bit of acantholysis right where they hit the epithelium. That's characteristic of PRP as well. And then clinically, what will PRP look like?
You have hyperkeratotic orange palms. You have erythroderma with piles of sparing. Kind of a nutmeg appearance with the follicles.
Nutmeg grater. Have you ever seen a nutmeg grater?
I looked one up on the internet when you mentioned it in your PowerPoint.
And we actually have one in my office. So usually I had to run down and see a patient right before we started. Usually I bring it to the session so you can pass it around. If you didn't grate your own for eggnog, I can show you a nutmeg grater later. Or you can look one up on the internet to see what it looks like. That is one faded slide. But you got to read it anyway. So, Paige, what do you think?
I mean, it's kind of looking just offhand like maybe a diamond kind of keratinocytes.
Like diamond-shaped keratinocytes in a flattened epithelium with 1 million plasma cells down below, a few newts in the corneum. What could this be?
Zoon's
Could be Zoon's. Zoon's looks a lot like syphilis on the penis, though. So, probably every case of Zoon's, it's probably reasonable to get a T-pal stain.
Okay, so I've got some bulbous, regular acanthosis.
So is it regular? Maybe not as regular as it might be. And when you look at your suprapapillary plates, are they thin or are they thick?
They look a little thick.
They look a little thick. In psoriasis,
They would be thin.
they would be thin. So you have not only very regular bulbous acanthosis, but your suprapapillary plates are very, very thin. In this case, they're very, very thick, just the opposite. What else do you have?
I've got some parakeratosis.
Is it confluent or is it patchy?
Patchy.
And where is it in the corneum?
Looks kind of mixed, like some up high, some down low.
Yeah, so some up high,
One
some
might
down low.
Say checkerboard.
Someone might say checkerboard. So you have irregular acanthosis, a checkerboard pattern of parakeratosis, thickening of the suprapapillary plates,
So I'm PRP.
PRP, and then you look down at your follicles where they hit, sometimes a little acantholysis. It's not always there, but that's one helpful clue. James.
Mm-hmm. So it's like we have some serum crust up there with some scale going off and some phase 3D. Let's see if there's needs in it from here. This feels like you don't intend for me to see more things. Because of the height. Yeah, so kind of newts and, right?
So newts sitting on top of para, and where are they in relation to features of the skin?
Kind of perifollicular.
Kind of right over the follicle and right over the follicle, so they kind of skip follicle to follicle. So you have a spongiotic process with parakeratosis, neutrophils, and crust sitting over multiple follicular orifices,
Like said.
like seborrheic dermatitis. Very good.
So you have an acantholytic epidermis, quite a bit of parakeratosis, and also looks like some sponge.
So acanthosis, spongiosis, parakeratosis.
So it'd be more like a subacute or even like chronic.
Yeah, like a subacute to chronic spongiotic dermatitis. Do you see anything else diagnostic in this case? No is an acceptable answer.
No.
Yeah.
No.
This turned out to be scabies.
Oh.
So remember, subacute spongiotic dermatitis is a reaction pattern. It's not a diagnosis. You still have to look. Is it contact derm? You know, what is it? In this case, the patient had scabies. We don't see the scabies on here. If you have crusted scabies, you're going to see mites in every biopsy section.
Mm-hmm.
If you have regular scabies, how many scabies mites are on your body?
Could be like 10.
Yeah, not a whole lot.
Mm-hmm.
The rest is your immune response to the scabies mite. What form does that immune response take in the skin?
Of a subacute.
Of a subacute spongiotic dermatitis. Exactly. So remember, spongiotic dermatitis is a reaction pattern, not a diagnosis. Then you have to work out, is it nummular, is it drug, is it contact, is it scabies?
It's a little bit faded, but right off the bat, there's some extravasation.
So red cell extravasation.
There's some pigment.
Yeah, there's some pigment. And if we look at the pigment like this, see how it lights up?
Yeah.
It's
So-
brightly diffractive. So what
Brown.
kind of brown pigment in skin is brightly diffractive?
It's Hemosiderin.
Hemosiderin. So there's a ton of hemosiderin. Your blood vessels
Mhm.
are kind of in nodules.
Right. So stasis.
So stasis. Stasis dermatitis. Very good.
It almost looks like a scar, but it's not.
Yeah.
So there appears to be regular acanthosis.
So regular acanthosis. Tell me about your suprapapillary plates.
There's thinning of the suprapapillary
There's
plates,
thinning of the suprapapillary
and there's
plates.
confluent parakeratosis.
Confluent para, and what sits on top of the para?
Neutrophils.
Neutrophils, and they alternate. Newts, para, newts, para, newts, para in a sandwich fashion. So what is this?
Psoriasis.
Psoriasis. What else can look like psoriasis?
Tinea.
So tinea could, but you know, what basically are other variants of psoriasis that we see in skin? If you have uveitis and arthritis,
Reactive arthritis.
so reactive arthritis syndrome used to be called Reiter's syndrome, except he was a bit of a dirtbag, so now they call it reactive arthritis syndrome. And the skin lesions look identical to psoriasis.
So I see parakeratosis, some acanthosis, spongiosis.
Yep.
So I'd say acute sponge.
So
Or subacute sponge.
subacute spongiotic. What do you see there?
Is that a scabie mite?
That is popped scabies eggs.
Oh.
See how they look like little scrolls or pigtails? Those are the popped eggs of a scabies mite. This is the same case, Jessica, that you had. This is step section 10, showing the diagnostic features. Let's make sure. Okay, for those online, here are the pigtails and scrolls that we've been talking about. So there you go, and there you go. So scrolls and pigtails, and that is characteristic for scabies or diagnostic of scabies in what otherwise looks like a subacute spongiotic dermatitis. Look at scan. It can kind of hide in the scale crust, except that nothing normally will give you pigtails and scrolls in the corneum. So when you see them, you just train your eye that they pop out at you as abnormal.
This looks like acute sponge with some intraepithelial
Kind of like an
vesicles and
acute sponge. And this is from a child with a peri-orificial rip-roaring dermatitis and horrible diarrhea.
So think about nutritional, in that case, zinc or acrodermatitis.
Acrodermatitis enteropathica. It doesn't have the swelling and edema of the upper third of the dermis, but in its acute phase it doesn't. It just looks spongiotic. So this is from a child with acrodermatitis enteropathica, but the acute phase is just subacute derm. Or I guess the subacute phase would be subacute derm. It's later that it forms the more characteristic pallor and swelling of the upper corneum.
Here we have some focal parakeratosis with some neutrophils.
So nude sitting on top of para. What does that make you think?
This gives it P-Tix differential.
P-Tix, which is?
Psoriasis, tinea, betiga, candida, syphilis subden.
Okay. And what other things might you see in syphilis?
Plasma cells, like cytoplasmia, lymphocytes, endovascular swelling.
Busy dermis, mix of interface and psoriasiform.
Right.
Plasma cells in 2/3, elongation of the redi if there are lots of features, and if there are few features, effacement of the redi. So not really seeing that in this case. So nudes on top of para, we do a PAS, it's negative. What are you seeing in the epidermis here?
Just like outside of the spine.
So spongiosis. Is there any form of psoriasis that can be spongiotic?
Guttate, erythrodermic, inverse, acral.
So
pustular.
exactly. So the types of psoriasis that are supposed to be spongiotic: inverse, erythrodermic, acral, guttate, and then pustular tends to be just around the pustule. Other forms of psoriasis, you have a distinct absence of serum and spongiosis. It's one of the things we look for in psoriasis, that you don't have serum and spongiosis. But there are 4 types of psoriasis that are supposed to be spongiotic: acral, inverse, erythrodermic, guttate. So, Paige, are there any forms of psoriasis that can be spongiotic?
Yes.
What are they?
Guttate, erythrodermic, inverse, and acral.
Okay.
Shane has a good mnemonic for that.
What is it?
Shane
I
came up with a good
say
mnemonic.
age every time I have to say the forms of psoriasis that cause spongiotic derm. So I age is inverse, acral, guttate, and erythrodermic.
Okay. Very good.
Yeah.
So, Rachel, I see spongiosis here, but I see newts on top of para. Could that be psoriasis?
Yes.
Any forms of psoriasis that could be?
It could be inverse, April, gutty, or epidermic.
Yep. And right now it all is right at the tip of your tongue, and 2 days from now it's like Teflon syndrome. Nothing has stuck. And it's like, well, I know there's some kinds of psoriasis where you can see it, but you got to merge it with the clinical. If the clinician is telling you gut tape, then you expect this. If the clinician is saying plaque-type psoriasis, and this is what you see, there's no way it's psoriasis, because that's not one of the types that gives you spongiosis.
So you have compact ortho hyperkeratosis, pretty diffusely. There's some para scattered in there. And a little bit of acanthosis.
Yeah. It's kind of minimal change disorder.
It does kind of look like it's alternating. It's the PRP.
Yeah, it brings up PRP as a differential. And
I don't see any acantholytic.
there's also a little bit of red cell extravasation, maybe brings up PR in your differential. So basically you're in a mild subacute spongiotic differential, and then you're looking for subtle clues that might lead you in one direction or another. And, you know, it's okay to mention both PR and PRP in a differential. The clinician looking at it clinically, it may be obvious, you know, it's obviously not one, then it's more likely the other.
There's some orthohyperkeratosis and then a little foci of little areas of serum crust and maybe some para. I don't think there's a corner on the mellow there.
Oh, but that's kind of the question, right?
Yeah.
So they did multiple sections, couldn't be sure, looked at the patient, it was Poro. But, you know, that one, the closest you could get is kind of suspecting it.
So, orthokeratosis, some maybe irregular.
So irregular acanthosis, and a lot of the acanthosis, see there's an eccrine duct coming up right there, and you can see the duct there. So a lot of this acanthosis is not the surface epidermis, but the adnexal structures that are reacting. That goes with PEH. So pseudoepitheliomatous hyperplasia disproportionately involves adnexal structures rather than surface epidermis. So that's why you have such a skinny epidermis with big things hanging off of it. Tell me about the papillary dermis.
Looks like there's
Fibrosis and vessels, so-called angiofibroplasia of the papillary dermis. So angiofibroplasia of the papillary dermis with irregular acanthosis goes with what?
Well, when I saw it, saying like, yeah, let's see.
Yeah, exactly. Lichen simplex chronicus. Sometimes you get really nice vertical streaking in the papillary dermis. Sometimes it's not really great vertical streaking. It's just angiofibroplasia of the papillary dermis. And that counts just as well for lichen simplex chronicus.
Getting an overall pattern of maybe like a stasis dermatitis here. See
What?
like some
Go ahead.
vessels in the dermis.
And the vessels, are they diffusely located or are they in cannonballs?
I think they're in cannonballs.
So you have cannonball type angioplasia.
There's some hemosiderin.
There's hemosiderin. Are you sure it's not melanin?
We can try to.
You can do a little diffraction, and it is brightly diffractive. The other thing you can do is if you go to high power and focus up and down, it tends to twinkle at you, and you can see it's refractile, whereas melanin's dull. So if it twinkles, it's hemosiderin. If it also hemosiderin, it's got a little bit of a greenish brown tint to it, whereas melanin is really brown. So hemosiderin a little yellowy greenish as well as brown. It is brightly diffractive, which you can see when you.
What gives it that property? Is there anything particular?
Oh, that it's diffractive. I'm thinking some kind of crystalline structure. I don't know, but it's a characteristic. So, and that's helpful for various pigments, like Argyria, cuz is the answer. Argyria is brightly diffractive, Chrysiasis is not. So, if that's your differential, Argyria versus Chrysiasis, all you do is you slide your hand over the condenser and it'll tell you Argyria versus Chrysiasis. So, it's some kind of crystalline property of the pigment, but some pigments are and some are not diffractive, and so it helps you in your differential. What are we time-wise? We've got time for just a few more.
So, this looks like I've got some sort of like dermal infiltrate.
So you got a dermal infiltrate of limbs. What's going on in the epidermis?
Some spongiosis.
So
It's
is
like a
it-
blister.
Yeah, and what kind of blister? The cells are round, they're floating apart from one another.
I'm not sure what you're going for.
So anyone want to help? That's acantholysis. So in acantholysis, your cell-cell junctions disconnect, so the cells round up into a round ball and float away from one another. So it's an acantholytic blister. But we also have acanthosis, parakeratosis, and when you look at the parakeratosis, where is it? It's up, it's down, it's in the middle. Do you know any kind of acantholytic disorder that can have a checkerboard parakeratosis?
Maybe like Elvin? No.
Or anyone? PRP. So remember, PRP can be acantholytic. It tends to be right where the adnexal structures hit the epidermis. Here you don't really see that, but just remember, acantholysis is okay for PRP. You can see it. We didn't see it in the prior examples. It's really prominent in this one.
Looks like we have a thickened epidermis with a little spongiform vesicle in the epidermis.
So a little spongiform vesicle in the epidermis, and a vesicle usually doesn't have pus. What do you call a spongiform thing that does have pus?
A pustule.
It's spongiform pustule. Very good, Professor Cluzo. So a spongiform pustule in the epidermis. It's kind of spongy in the background. So you've got a spongiform pustule, it's spongy in the background. What could this be?
Pustular psoriasis.
Pustular psoriasis, and any site where pustular psoriasis may have a lot of sponge?
The palms, folds.
Erythrodermic augmentate, that's correct. So,
Why
and
would
this
that
one
be
might
sort
be,
of
looks like it could be an acral site.
situation.
So, acral psoriasis that's pustular, that certainly can have lots of surrounding sponge. So, that's what it kind of looks like histologically. The history is this patient has no history of psoriasis, but started on an antibiotic, a beta-lactam, and then acutely went red with a swollen face, pustules all over the hairline, a few pustules elsewhere.
Age up.
Acute generalized exanthematous pustulosis. Correct. So again, you got to put it together with the history and tells you what the patient is likely to have.
So I see some mouths of what appears to be para.
Okay.
And then some spongiosis.
And
or
some
a lot
spongiosis.
A lot of pretty heavy infiltrate there. Some extravasation.
Tell me about your limbs.
They're sort of forming little abscesses. Almost.
Little abscesses. And are they round?
They're sort of angulated and atypical.
And tell me about the infiltrate around your vessels. Is it symmetrically around the vessel?
You know, you got that flat belly.
So you've got a bare, the bare underbelly.
Bare underbelly. Sorry.
So you've got a bare underbelly to your vessels, and you've got large hyperchromatic angulated limbs and collections in the epidermis. So what is this?
Mycosis fungoides.
Mycosis fungoides, despite the fact that there's some spongiosis. MF, classically we say MF no spongiosis. You look at flexural sites, you look at many of the sites where psoriasis is spongiotic, MF is also spongiotic, usually not to the point of microvesiculation, actual vesicle formation, but spongiosis is not uncommon in MF. And certainly in treated MF, it's very common.
So there's a lot of neutrophils in the sternum corneum.
And are they all in one
Parakeratosis.
place, or do they alternate?
They alternate.
Kind of in a sandwich fashion.
So psoriasis is
So suggests psoriasis, but I see spongiosis. Can you ever see that in psoriasis?
yes.
What forms?
So the IH differential,
Which is?
inverse, acral, guttate, and orthodermic.
And erythrodermic. So IH or inverse, acral, erythrodermic, guttate, if that works for you. So take that slide off and tell me what things can give you a mix of interface and spongiotic dermatitis.
Syphilis.
And if you have syphilis that's on the trunk and has very few diagnostic features and the differential was rule out drug, what other features are most likely to be there to help you?
So usually the papillary dermis is effaced. There's endothelial swelling. There's a significant amount of cytoplasm in the lymphs, and there's a busy dermis.
Very good. Okay, we're done.
I didn't even know you were here. So.
Not again.
Yes, I did.